from now, and I've had a chance to add most of our advisory council members as presenters. So if you'd like to have your cameras on, you're more than welcome to do that. But optional, I know a few folks are in transit and joining us, on the road or in airport. So if you're not able to, just fine. We are missing just a couple folks. I know Mallory Shaughnessy was unable to make today's meeting and let me know that. And I believe Heather Perot was out of office hoping to join, but I don't see her on yet, and it's almost 5 after. So I think we'll go ahead and get started. Maybe she can join us later. We do have an advisory council member who I think is able to join us today for the first time. So I did think maybe before I jump into the agenda, we could just do another quick round of introductions, just to give a chance for everyone to kind of get to know each other and put faces to names again, if you all don't mind. So I think we'll do the same as the first meeting, just who you are in one sentence or two of context about you. And maybe we can get started here in the room and start with Katie.
Hi, Katie Fulham Harris, Representative Graham. Are you our new member?
No, I just haven't shown up for the first time.
Oh, okay.
First time joining us all together, not first time in the room.
Got it. I am, I lead government affairs at Maine Health. Really happy to be here.
Kate Indy, she, her pronouns, and I'm the policy director at Consumers for Affordable Healthcare. Likewise, happy to be here.
Great, I'm Trevor Putnaki, but I'm the CEO of the Healthcare Purchaser Alliance.
And I'm Representative Andy Graham, and I represent House District 105, which is North Yarmouth and Gray, but I'm not here on that capacity. I'm actually, I represent providers on this commission.
Thank you. Turning it to those who are on virtually. Heather is joining us right now, so I'll start with others and then hopefully turn to her. Actually, Renee, do you want to go next and introduce yourself?
Sure. Hi, everyone. I'm Renee Fay LeBlanc. I'm a internal medicine doctor and work at a health center in the Portland area, and happy to be here.
Great, thank you. Let's see, Christy Daggett.
Good afternoon. I'm Christy Daggett. I'm the Chief Financial and Administrative Officer at AMHC, a behavioral health and substance use agency serving Aroostook, Washington, and Hancock counties. Nice to be here today.
Thank you, Christy. Let's see, Jordan Rhodes.
Thanks, Meg. Hey, everyone. I'm Jordan Rhodes. I'm the Director of Research and Policy Analysis at DHHS.
Jeff.
Hi, I'm Jeff Sanford. I'm a VP of Finance at Northern Light Health. My focus tends to be on value-based care.
Perfect. Trish.
Hi, I'm Trish Riley. I'm President Emerita of the National Academy for State Health Policy, and the service guy I've been waiting for just arrived, so I'll step out for a minute.
Sorry about that, Trish. Thank you. Tough timing. Heather, I shared with the group, Renee is joining us for the first time, so we were just doing a brief round of introductions for advisory council members. If you wouldn't mind introducing yourself.
Absolutely. I'm Heather Perot. I'm the Deputy Commissioner of Finance and Human Resources for the Department of Administrative and Financial Services. I'm responsible for the State Employee Health Plan, and I also serve on the Advisory Council for the Prescription Drug Affordability Board.
Fabulous, thank you. And Kevin, are you able to introduce yourself?
Hey, Meg. Yes, thanks for your accommodation. Kevin Lewis, I'm the CEO of Community Health Options. I use he, his pronouns. And I represent the insurance industry per se, and happy to be with you all.
Perfect, thank you. I haven't seen Carl join, who I think is the last person. So I think we'll keep moving, and if he joins later, can give him a chance to introduce himself. But I'll just jump right into the agenda then. Excited, this is our third gathering of this group, and coming out of the first public hearing for the office in September, a good amount to cover today. So I wanted to start, we just have a couple items of council business. I want to spend some time reviewing the input that was received through that public hearing process. I want to spend some time discussing the analytics agenda for the office. We've touched on that and spoken at a high level in some previous meetings, but between the last meeting and today's, I've really been working on putting a framework around that and really solidifying some plans. So I would like to review that with the group. and then chat about a few upcoming events of interest, and then we will wrap up. So the council business items I put at the top because I'm hoping these are relatively sort of quick ones. A lot of it is really follow up from the last meeting. So the first of those is the council charter. We discussed this a little bit at the last meeting, but then I wanted to make sure folks had plenty of time to review. And we also received some feedback, which I incorporated in the version that I sent out yesterday that had highlights to indicate a few places where I made some changes and additions at the recommendation of the group. So wanted to, pause there and see if there's more discussion that's desired on this, or if we're, at a point now where folks would feel comfortable voting to adopt this, at least as the first iteration of the council charter, acknowledging, as it says at the end, that this is a living document, something that the group can revisit if there's times when it's needed or just on an annual basis to check in.
Yeah.
Motion, if no one has any comments, I'll move to.
I just have one quick, you're missing an R in Strive.
Thank you.
3-2.
The issues of having no one to proofread for me.
I moved to add an hour just right.
Formal motion adopted.
All right, I will move to accept the charter.
I'll
That's great.
second.
Do you want to do a roll call vote or?
I think we should just do it by hands, maybe, if you go.
Okay, yeah.
Everyone that says aye,
Aye.
Aye.
any nays? Those folks online might need to speak up. It's a little hard. We can't actually see you all at the same time. If there are any nays.
Great.
Sounds good.
We'll consider it adopted. Thanks all. The other item that I had here was just a reminder about the conflict of interest form. That's another that we shared at the last meeting, but I wanted to give everyone a chance to raise a hand privately if they had questions or concerns. I hadn't heard any of that, so I did bring hard copies for the folks in the room today so they can just complete it if you haven't already. And I can send that around after this meeting again to those who are virtual. I would just ask if you can sign it at some point and send a scan to me. My goal is kind of have all those completed by the next meeting, so no immediate urgency, but just another item that we can wrap up as part of our startup activities. I'll also briefly pause here. I didn't have sort of an operations update in this deck, in large part because unfortunately several items were kind of stuck in limbo, but I did get some good news about 2 hours ago that I got final approval to post the analyst position. And that usually, the posting step usually is actually pretty quick from my prior experience. So I would say within a week or so, should be able to have that up and then start the process of bringing someone else on. So they can catch my typos and doesn't have to. So I did wanted to share that as just a positive development. The website work is still underway, and I just hesitate to say, I think again that we are close to the finish line, but I thought that before. So I will definitely send a note out to the group when that is actually fully completed and live, because I know it will help a lot with transparency and sharing information, which right now is a pretty onerous process on both sides for everybody. So knock on wood, progress there, but I'm very excited about the analyst position and being able to bring on the first staff member.
If it would be helpful, Meg, I'd be happy to share that position through our channels. I don't know if others are.
Likewise, really, as soon as it's posted and up on the jobs board for the state, I would love to share it and definitely love help promoting it in everyone's networks to try to get as strong a pool of candidates for that as possible. Great. So moving on, sort of the administrative pieces. Wanted to go to talking a little bit about the experience with the public hearing, which I thought overall was a positive first public hearing. As I had mentioned, I think it's early in the office's work. I think the structure of that meeting and how it's framed and how comments are requested, can change in future years, but had about 35 respondents, either in person or written comments or combined, which I thought was a good representation and pretty decent participation. A couple thoughts in terms of the process of summarizing this, because it's something I've been struggling with over the last week in terms of reading the comments. I think the process of summarizing always by its nature is going to lose some nuance and some specificity. So one thing that I wanted to say just upfront for especially folks who submitted comments, as I go through this summary, just because something isn't included there doesn't mean that it hasn't been heard and that it's not being considered. I just felt like for the process of creating a summary of this and a readout for legislators in particular, which is one of the main audiences, you know, I needed some framework to kind of narrow down, and the way that I did that felt the most fair and even-handed was really looking at where I saw themes from multiple commenters in a given sort of category and highlighting those rather than sort of doing my own picking and choosing. But that being said, I think there are ideas that maybe were mentioned only by one commenter, but that are really interesting and that I might be scheduling follow-up meetings to talk about, or, you know, just keeping back of mind during the course of the work. So only wanted to say that because, again, I didn't want folks to feel like this was purely a numbers game and just about consensus, because there is more to it than that. And there were many comments that were very detailed and very extensive. The other component that was a little bit challenging and where I made changes throughout the process of summarizing was even defining these categories of different sort of respondent types, which I did feel like was important to give a general sense of who commenters were. But a couple areas where, you know, there are overlaps in people's identities and the perspectives that they're representing. And so I just felt like I kind of had to use my instinct at times to determine where to categorize them. A few places where that was particularly true, I would say in the individual category, I ended up really trying to limit that to folks who were speaking from lived experience. So even though there were sometimes folks who were submitting as an individual, it kind of was a little bit more about a particular policy perspective that they had. Individual, I really tried to focus mostly on patients. Although I did include in that category, we had 2 individuals come and speak in person who are community health workers. And I did include them in individual in part because I felt like their commentary was really sort of summarizing the interactions that they had had with community members, and still was very much sort of like an on the ground experience that they were representing. But that being said, I, you know, thought they could be an advocacy, or to some extent could even be over on the provider side. So just want to acknowledge that. And it's one of the things where, you know, frankly, I'm open to this group's feedback about that. If there's different ways that you would categorize, you know, either your own organizations or others, because it's obviously not a totally black and white issue. The other that was a little bit nuanced was kind of the association versus provider distinction. So there again, I really kept the provider section to, it's mostly individual providers, but a few different folks kind of submitted on behalf of a small independent practice and chose to frame it that way, versus the associations. You know, I included Maine Medical Association and the PBM Association, sort of representing different categories of provider there. The last quick note that I'll just make is I did, just for purposes of simplicity too and categorization, include in the insurance company and hospital and health system categories, each of their associations submitted comments. And so rather than putting that in association, I included it in their categories, just based on, to some degree, kind of alignment in the comments and the smaller nature of those categories. So you can see advocacy and individual comments made up a little bit more than half of all the comments that we received. Then providers and associations, you know, close behind, and hospitals and health systems and the insurance companies, each coming in with kind of 3 different comments. One thing that I wanted to highlight was there was a lot of consistency, by far the most consistency in the category where I'd asked respondents to talk about the challenges that are specific to Maine, or characteristics of Maine that should be considered. Probably not a great shot, but I did want to call it out. So those were the rurality of the state. And I think a few different angles on that. Rurality in the sense of the challenges of providing services in big geographically dispersed areas. Rurality in the sense that there is a typically greater health need among rural residents. And then the last element of that was called out by several commenters was internet access and the difficulty of providing, for example, telehealth services in rural areas. So kind of I used rurality, but there were several distinct kind of issues under that umbrella that folks called out. The relatively high average age of the population was also noted, and would definitely say that that was specifically in the context of discussing higher healthcare needs among that population. Lower average income was also noted, which I would say mostly sort of relative to other New England states. And what I thought was interesting and worth noting was that many commenters called that out, but specifically also within the context of there being a higher cost of living here, that, you know, that we're different from some other lower income states nationwide, where cost of living is also kind of commensurate with income, that we really have this divide here that can be challenging, again, through I think a few different lenses, one being health need, one being the difficulty in affording premiums and pocket costs can be different here. You know, a premium at a certain level that might be affordable elsewhere might be much more of a financial constraint on a family or individual here because of the cost of housing that they're experiencing. And the last one being, you know, a component of workforce there too, that there are some particular challenges in terms of recruiting and retaining workforce here because of that kind of economic issue. And then the last item that was called out by several commenters was the heavily consolidated provider landscape in the state, in particular the Portland area. I'm gonna pause for 1 second, just to say, I got a note from Carl, and I think we might be having some trouble.
Well, Meg, I'm sure the consolidation is as acute an issue in the Portland market as it is in some of the other markets around the state. There actually is some provider choice in that market, unlike a lot of other places.
There's actual competition there, but.
I will say, in terms of delivering the themes, I'm trying to summarize and not. Others, I mean, I think that can be part of the conversation, but it's a good point for me to make initially that I tried very hard, which isn't always easy for me as I was summarizing, to kind of not interpret or not weigh, but to really just try to do my best job of conveying that. So at least one or two had mentioned, I think, and it may be limited because of how urban Portland is, that it is on measures that aren't, you know, that don't include more rural areas where it's more difficult to like define service areas. So that may be part of it, but sure. Yeah. And sorry, I'm just want to make sure. I'm not sure what to like. I'm gonna kind of try to keep going. The difficulties of technology. Because I don't see trouble in the waiting room. So that was the sort of themes in terms of, as I said, the main specific challenges, which were pretty consistent across all commenter types. Next, I wanted to kind of go by category and just talk a little bit about what I saw in themes. Probably to no surprise, the individual category was probably the hardest one to kind of find themes in, because there was a lot of variation in terms of what folks reported. But again, probably not to anyone's surprise, a theme was definitely just generally premiums and out-of-pocket costs as a barrier to care. You know, we had a really compelling individual come and speak to his employer-sponsored plan and the challenges of having to meet a deductible every year when you're someone who is always going to have a health need. You know, that it's not an if kind of situation, but certainty and how to manage that. The other theme that I saw, which is a little bit of an amalgamation, but I thought that it was a good way to try to summarize it, is complexity of systems. And that was expressed in a few ways. One being, I think, navigating coverage options and enrollment and eligibility processes for public programs, but broadly, really, for all coverage, trying to understand the options. You know, what do you do when you've missed a special enrollment period? So that was called out in several of the comments in various different ways. And the other being navigating plan benefits and costs. And several of the commenters really called out the difficulties when they feel really stuck between an insurance company and a provider, and we're sort of finger pointing going both ways, and they have a hard time navigating not even getting it resolved, but even who they should be going to get it resolved, and a lot of struggles with responsiveness there. So I thought I would call that out because it's such a pain point that almost feels, you know, outside of policy and really more about practice, is something for us all to think about.
And law. No, it actually, if I could, just there is policy related to it, because it's oftentimes when there's a third party payer involved, like when there's an auto accident or something, and it can take sometimes years to get those resolved and to get the final bills.
Yeah.
And so, and some of that's driven by policy.
Yeah, and I'm certainly not trying to say it's independent of policy, but just that there's a mix of policy and just like the processes, which I you know, having worked at the marketplace, like I relate to, it can be really hard when you have a call center to figure out like what gets escalated where and how do you get the people to give the right answer. So totally hear you. And in fact, you know, speaking of the policy there, one of the comments was about ground ambulance, surprise billing. So a place like where we know that there's this gap, in policy, but again, for someone, you know, just experiencing that, like
Yeah.
the level of complexity in their personal circumstances versus the policy, level is really, challenging. The last piece, was, some themes in terms of lack of clarity and consistency in hospital-free, care programs. That was a theme in some of the comments, that were delivered in person. Definitely an area that was interesting for me to learn a little bit about, having been more historically on the coverage side myself. I'm less familiar with free care, policy. So, did want to call that out because, some community health workers spoke about it, but several of the advocacy organizations you'll see later did as well.
Oh, I will look forward to that. So just so you know, I did follow up with those two community health workers, because I was horrified to hear some of what they were saying, and I think so we have a meeting in November.
Well, and I will just say, I think, you know, some of that sounded like variation even among hospitals, if that makes sense, or between, okay.
It's pretty much all, I mean, they're focused at Maine Medical Center. They may have been pulling from what they're hearing from others, but that was when I followed up with them.
Great, well, I'd love to, you know, have a follow-up conversation on that too, if it's an area where I'm getting educated, so, it does feel like, you know, a place, a little bit of like low-hanging fruit if there's, clarification or, assistance that can be provided.
Speaking to the experience of our helpline, you know, I think we've heard about barriers outside of the main health system as well. So.
Oh, fair.
Just-
Too, when I followed up
Okay.
with them, I said, is this about me?
Got it.
Because that's where the clinic, that was all about asylum seekers and immigrants, and we have the clinic for them. And
Got it.
So that was-
I was gonna say, I do remember from some comments, distinct discussion about like variation among health system policies. So I
Yeah,
did have
that's
a sense that
probably,
it was
no
broader.
doubt about that.
Yeah.
So moving on, to advocacy, I should say on, individuals too, many individuals, you know, didn't, say, here's the policy solution. It was more like, here's the problem. I would like to have it fixed, which doesn't surprise me, totally fair. So that's why I did kind of summarize, policy ideas. I did do that for most of the other, categories here. So moving on to advocacy, again, high premiums and out-of-pocket costs. You know, I don't think, I will just say on this slide, like there was a really strong, it's premiums, we need to focus on that so we enroll people, or premiums aren't an issue, out-of-pocket costs, which doesn't surprise me, but I was interested to you know, really focus on what's together. But I think there's a recognition that both of these are kind of continuing problems, in terms of uninsurance and underinsurance. Several of the advocacy organizations, reference the high cost of prescription drugs, you know, largely here, I think from a, consumer perspective in terms of shock at a co-insurance, amount, for example, but to some extent too, the part that plays in, premiums. And then another, pretty clear theme from, several of the comments was about eligibility gaps based on immigration status. And I guess I, would clarify that to be, you know, full gaps in eligibility, like ineligibility based on immigration status, and then types of eligibility, based on immigration status. So, you know, referencing the 5-year, waiting period for Medicaid for certain people with certain immigration statuses who are eligible for the marketplace, but kind of concerned about marketplace plans not being the best option for that.
That's a quick question.
Yeah.
And, I apologize, I did read this, but I was in Chicago listening to healthcare costs while you were doing this last meeting. So, the eligibility gaps, and I'm looking at Kate a little bit here, but, are there other, individuals who are experiencing, eligibility gaps, other than the immigration, new Mainers and immigrants? So are you seeing that?
I mean, I think in terms of main care, immigrants, you know, certain, depending on statuses, so it's not all immigrants, right? But for certain statuses, you know, are just completely prohibited from
Right.
qualifying.
Yeah.
So I don't think any other group faces that same level of
Okay.
exclusion.
Okay.
There's people that, you know, perhaps are just slightly over income or, you know what I mean? But like for some other reason, it's but nobody else is really like barred from the program in the same way.
Okay, thank you.
So moving on to policy recommendations, reasons there, I'll maybe group the first two bullets together. I think, there were a few categories of talking about kind of reforms to the health system. The first being introducing a public option health insurance plan. I think most of the comments around this were pretty generalized, not super specific about what that would look like, but kind of the concept of introducing something publicly administered that would kind of compete on the market with other plans. And then a category of folks, both in person and who submitted written comments, who their focus was really on developing like a single state administered coverage program that would kind of cover everybody except the Medicare population in Maine. And a lot of those comments reference like looking at international models. So I hesitate to use the word single payer, because to me, a single payer, would be inclusive of Medicare. I think that that's not, but I think that some of the commenters would classify it that way. And I did want to differentiate those two sets of comments and sort of pieces of feedback, and that there's a little tension there in those two models, but definitely a lot of interest and support in insurance and coverage models, and using those as sort of like a vehicle for broader reform of the system. Directly related to the last gap in barriers, many commenters wanted to essentially eliminate immigration status related eligibility criteria for Maine Care. There were a few comments, and I grouped these together, though some of them describe them separately, but generally thinking about regulating prices for some segment of hospital services and or prescription drugs. A few different comments mentioned the idea of using reference-based pricing, and not typically sort of across the board here, but thinking about things like out-of-network services, and should there be a reference-based cap on those for hospitals or for prescription drugs, looking at the new Medicare program to negotiate prices for a certain segment of drugs and following that at the state level. And then the last bullet point here mentioned in a few different comments about prohibiting anti-competitive terms in provider contracts, so anti-tiering, anti-steering clauses in contracts with health insurance companies. So next, the provider category, again, which was sort of in either independent individuals who are themselves doctors or some form of medical professional, or a few different kind of independent provider groups that submitted comments. This was a very consistent theme, discussing the high administrative burden that they face, and it kind of two lenses on that one too. I think some talking more about it as a cost driver in terms of we have to hire people to do this, or we have to take our own time and we have to find ways to be compensated for that, as well as a concern about how that contributes to burnout for especially primary care providers in the state, and creates these shortages that then really sort of harm the broader health system. So we definitely cut that one out. I had a hard time summarizing this one, but it was a theme that I felt like I could pull out of several comments. Discussing care coordination, especially among different entities. I think for some of the kind of independent providers, they felt like they struggled a little bit to figure out, how do I help navigate care for my patients, especially if it's with health systems or different specialists that are outside of my practice. And I wanted to include in that because a couple folks mentioned it. EMR, electronic medical records, sort of fragmentation in different systems, and the hard time kind of sharing information about patients. Fair amount of that was sort of higher level, but it felt like enough of a theme that I saw in a few comments that I did want to pull it out. And then a few also specifically mentioned that they felt that there was really a kind of systemic underinvestment in primary care here in Maine, and probably broadly as well, just in the way that our health system is structured. This was a group, it was a little bit hard to see a consistent policy recommendation. I think another that the comments sort of skewed a little bit more to sharing experience and feedback. And there was variation in the policy recommendation piece, but I pulled out this concept of support for thoughtful value-based payment reform that considers provider burden. I added a few caveats to that because there was definitely some feedback from folks who were like, I was in a model and I really didn't like it. It didn't work well for me. So I don't want to interpret all of the comments as sort of this great. But I think there was a general sense of like, we do appreciate paying for value over volume, and we understand the role of that in supporting primary care practice and independent practice. So with some caveats, but that some folks were really on board, others were a little bit more sort of hesitant and cautionary with their comments on that. I think third to last group, associations, this one even more than individuals, I'd say would be a hard one to summarize. And that's really, I think because there were several organizations in this category that were looking at a particular service category, type of specialty, a little bit more specific in their focus. So it was a little bit harder to kind of pull out common themes. That being said, I think across the board, there was acknowledgement of the issue around costs, and that costs are a barrier to care, and sort of a willingness to highlight that, and the visibility of that, on the provider side, that they see it and experience it themselves. Similar to the independent providers, I think it's fair to say that this group, in general, in different ways, supported prioritizing low barrier access to primary and preventative care. That took the form of, some suggestions about removing out-of-pocket costs altogether for certain categories of care, or just greater investment in primary care. And I use the same bullet point here, right? It was a similar kind of interpretation or nuanced approach that, again, brought sort of in concept support for value-based payment reform, but with cautions around making sure that it's kind of provider-led and that there's provider input. So next, hospitals and health systems. Fewer commenters here, but I will say this was a category where I did think there were some really clear themes that emerged. Both health systems that commented noted the challenges of the pandemic, and not just challenges of the pandemic, but sort of follow on impact, especially on workforce and sort of what I classified as like recovery from the pandemic. Both noted age and income level as means population as drivers of higher health needs relative to New England. And mentioned inadequacy of reimbursement rates in government coverage programs. Here, again, slightly different framing, but I hope it's a fair interpretation that I think both really focused in terms of policy on the continuum of care. A lot of concern about, people remaining in EDs or in the hospitals where that's really not the appropriate setting for them, just because there's not an adequate alternative to refer them to. And so really a focus on trying to solve that problem, both through rates, but also, really looking at that holistically as like a big care delivery reform effort that the state should be considering. And then both comments I wanted to kind of call out, were clear about wanting to make sure that the office's work and the state's work on affordability also consider ongoing quality of care, and that, while we prioritize affordability, it certainly shouldn't be at the cost of quality and outcomes.
I think you have done a really nice job summarizing our comments. Two things that I don't see here that I think were intended if they didn't come across. One was the importance for this group to use data that is agreed upon, sort of an agreed upon set of data. So that's one. And then that's neither a barrier, maybe more on the policy recommendation for this group, but the other is just related to quality access. I think is probably even more important than quality. And if that didn't come across in the comments, I think it was intended to.
Yeah.
Because access is the trade-off oftentimes these days around affordability.
Can you talk a little more, Katie, what you mean about quality access versus just quality alone?
Oh, access to care. So closure of services. So if we if we make recommendations around steps that result in closure of services, that will impact access,
Gotcha.
not just quality.
Yeah, gotcha.
Yeah, I would say on that second point, 100%. Even as you're saying it, I was like, oh, I remember thinking about access and quality, and I just, failed to capture it, pull it. So that was just an oversight on that. The data one, definitely heard that loud and clear in MHA comments. I hadn't included it just because I didn't see it come across as much as the others. I may have just missed it, or it may have been sort of a structural component. I'll maybe pause there. I know we're mostly kind of looking through, but as we have a chance to discuss this, because I was thinking about it after the commentary. I think we should have a more focused discussion about it, but I also, to be honest, am concerned about the idea of defining data sources before we define all the questions that we're trying to ask and answer. This office has an enormous charge. And I see that as something that we should be having conversations about in the course of analysis that the office is pursuing, like the conversation that we're going to have, later in this meeting, rather than trying to say at the outset, let's define data sources, just because I think we'll restrict ourselves more than is necessary. I don't think in practice it will really work for the office, given that at any given time, I might be tasked with looking at something different. And because, as we know, all data sources in healthcare have their drawbacks and their challenges. So I think there are some that are really obvious foundational data sources for the work, like MHDO claims data, but we know there's so many gaps in claims data. If we're talking about wanting to make sure that we are prioritizing access and quality alongside costs, then claims data isn't where we necessarily want to be looking. So I hear that, and I guess I want to find the right way to have that conversation, but I do also kind of want to make sure it's clear that I really see that being something where we discuss it in the context of an analysis rather than something that we do at the outset of the office's work.
And I'm not sure the intent was to define the sources ahead of time, maybe the criteria that you would use to identify the sources was, I think, more of the intent related to that.
And I think that's fair. I think the other thing that I'll say about that was, at least in Jeff's comment, the use of data source versus methodology to me, are different. And I think defining methodology and being able to talk about methodology is a little bit different than defining data sources, unless we're like at some point something like national health expenditures, that's a good source, but there's a lot that you can do in how you interpret that data.
Yes.
That might be more the area of concern or where we would want to have conversations about how we interpret the data. So that's the other piece. I think we need to be clear. And again, it's like I can't outline a methodology now, but I'm very willing to have iterative conversations with this group as we do analysis about methodology, and be prepared to, stand behind it and explain it and provide context where needed.
Yeah, I think we could pretty easily get bogged down in this data conversation. And I totally understand the hesitation of relying too heavily on any one source, but to the degree we have multiple sources, maybe none of which are perfect, but are all pointing in the same direction. I think it's fair to draw some inference from that.
I would want to make sure that we're using publicly available data sets, or that we agree, if it's not a publicly available data set, that it is a data set that we agree is a reasonable one.
Yeah.
And that, I think you can do a Google search and come up with the answer, a data source to support whatever position you want to have supported. So that's what I'm just trying to ensure that we avoid, so that we can all sort of hold hands and say the data really does point in this direction, regardless of what our position is representing an organization.
Yes, yeah. And I think that kind of ties into the next conversation, so maybe we can pause, but there's more to talk about there. But the difference between, coming into this office, I had meetings, and so I was pulling data from, I stand behind those sources. I do think they're reliable, but like looking around at what are studies telling us about this issue, both in Maine and nationally, and presenting that, as the office matures, and now that we have some resources, I see the office producing more analysis of our own, which I think answers to some of that question.
Absolutely.
Okay, great. So I think finally, I think this was the last group, was feedback from insurers. So again, a couple insurance companies responded, and the Association of Health Plans. Some variation here, but there were a few through lines among two or more of the responses. Barriers and challenges, highly consolidated provider landscape was highlighted, I think, in all comments. Limitations placed on utilization management in state law was a common theme. And the way that I interpreted that was both, to some extent, maybe some existing laws that had passed, but sort of ongoing conversation about that and some caution about the impact on prices and cost when utilization management is restricted. Pharmaceutical costs were called out, and particularly specialty pharmacy and what I call physician administered, because I think that's the Medicare terminology, but essentially like outpatient drugs that are provided in a medical setting, like infusions. Reduced impact of Megara on individual premiums due to the market merger was also a theme in a couple of the submissions as well. So for policy recommendations related to those issues, probably no surprise, kind of the corollary was reconsidering and being cautious about utilization management limitations. There was also the mention, I think maybe in all comments, but certainly a couple about studies of coverage mandates and consideration of the impacts of those. I will say that this was a bullet where I did my best to interpret. I think there were maybe at least one comment that veered a little bit more towards sort of like no more coverage mandates, and others that were a little bit more of a like they should be carefully considered and the cost should be considered. So there was a little bit of interpretation there in summarizing. Prohibition on anti-competitive terms and provider contracts, that similar bullet from advocacy was carried over into several of the comments submitted by the insurers. And then the other, again, directly related to the final bullet was reversing the merger of the individual and small group markets, and by default then eliminating reinsurance for small group purchasers.
You have the providers complaining about the administrative burden of the insurers asking for more. So that's the classic. I'll look at Dan over there. That's the utilization management. Absolutely.
Does seem like there should be some opportunity to sort of streamline.
Yes, exactly. So
we can find the middle ground.
yes, big low hanging fruit.
Yeah.
This is the danger of coming in person. You can get called out. But I agree. There's tension there, but it also feels like potentially some area of opportunity in terms of like, what is the process for doing that and how directly is it actually targeting, misuse or overuse versus just being an extra kind of layer of bureaucracy. But I hear you. I feel like that is a theme and a dynamic that any of us who have been in the HCIFS committee,
Absolutely
have seen. So no surprise there. So I have as the next agenda item, the analytics agenda, but I want to just pause, especially if there's folks who are virtual, if you have any questions, feedback, thoughts on the outcome of the public hearing. And maybe I'll just briefly say, I will probably try to use this as a basis and turn kind of this structure of the slides into a section of the office's annual report that's due at the beginning of January, just to give legislators a readout on this. I'm hoping very soon, like I said, to have the website, so all of the comments in full will be posted. So anyone who wants to dig in and read them in full will be able to. And then we did also record, and it's on the YouTube channel now, the public hearing. So we did have a handful of folks who only spoke in person and didn't submit written comments. So their thoughts are there, though I did include summaries of their comments in this summary that I produced. Renee.
Yeah, so thank you. I just have a question about, is this sort of a one and done, or are there other public hearings planned, potentially in different parts of the state to see if we get different feedback, or what happens in terms of trying to get more information moving forward?
Yeah, that's a great question. Definitely not one and done. Having an annual hearing is a annual requirement of the office, so need to do that every year by I think it's October 1st. And this year, again, like I said, the office is very early in its work. We're not at a point where we kind of have like a policy concept or original research of our own to present for feedback. So I think that the structure of the meeting will change. I hadn't given thought to the possibility of doing meetings in different parts of the state. I definitely would like, and we talked a little bit as a group about allowing virtual comment. It was something that I just didn't do this time because I am by myself, and even today, the managing of virtual participants can be a little bit of a challenge while you're also trying to lead a meeting and listen to folks. So definitely want to add that as something where people can comment from all around the state, and obviously they could in writing through that submission process. But I'm open to the idea if folks feel like there would be value in it of kind of going around the state. I think what I would say though is, especially from the perspective of individual comment, I want to make sure I'm not imposing too much on people's time and really value people coming in and sharing their stories and talking about their experience. But to some extent, it's like, I'd like to be in a position where I have something to share with them in terms of a direction and a really clear way to like take in and utilize their feedback. So just probably finding a balance between, wanting to be out in the state and definitely promote this office and more awareness of it and more of an opportunity for it to be a conduit of personal experience and preferences up and into government, but also wanting to do that in a way where it's really meaningful for people. Don't want to do it sort of just for the sake of being out there. So it's an area where definitely I value this group's feedback and recommendations about when and how that might be worth doing. I don't know if that answers your question. It was a long answer, and I'll be honest, having just finished this meeting, I haven't given a ton of thought yet to what it might look like next year. But again, if it's something where folks in their communities or with their stakeholders think that people would really like to have like an in-person interaction around the state, that's something I'm more than happy to look into doing.
Thank you.
Hey, Meg. It's Kevin, can you hear me okay?
Yep, we can.
I just wanted to interject and to be a little cautious with one of the through lines you mentioned on when you mentioned the advocacy, our position, or at least my position, on decoupling the individual and small group markets. You went on to say that the position was to essentially take away the benefit to the small group market. And I want to be careful because the focus is on retaining value of McGarrah in general. So retaining value of McGarrah seems to demand decoupling of the markets. And then let's focus on what does the small group market need de-stress and to realize a better functional performance. So I want to be cautious about that comment you made at the end there, because I don't think that was anything that certainly I advocated for, and I don't recall that in any of the other statements.
I hear you on that, Kevin. I guess I'm just curious. I mean, reversing the merger of the individual and small group markets would by default eliminate reinsurance for small group employers. So I understand that is not the desired outcome. I think I included that in part because it's just, I do think it's important to consider as an element of what that policy would mean.
But then you need to also include the other part of that, which is bringing the small group market up to 100, so you effectively double the pool size of the small group market. And what did the studies show in terms of the beneficial impacts of making that policy change? You can't do one without the other. You can't just paint the picture that somehow we're trying to rob the small group market of a reinsurance mechanism.
I mean, theoretically, we would want to look at changes around like a small employer's ability to level fund or go through captives or other things that undermine the risk pool in those markets.
I will say, I hear you on your comments there, Kevin. I don't know that was consistent throughout all comments in terms of my attempt to summarize here that in all cases there weren't necessarily direct alternatives being proposed as an alternative option in the absence of reinsurance. So I hear you. I think that's a valid point. I'm not trying to say, that is, I guess, a goal of the policy, but that I do think it's important to consider that is a component of what reversing the merger of the market would mean. But I'm happy to make an edit to that, certainly in terms of, characterizing this to others to say reverse merger of individual and small group markets and associated reinsurance and take different steps to stabilize the small group market, something like that, if that, feels more more consistent with your perspective and others. But I did just want to say, I hear you that might not be the best way to summarize your comments individually, that it was just the reversal of the merger that I saw as a consistent recommendation throughout comments.
I think that would be good to include there as you described it, Meg. So thank you.
Okay, thanks. Anybody else? Great.
I just want to point out there is a comment in the chat. I don't know if you want to, if you can see that from in the room or not.
Yes, I think it popped up for me for a second and then went away. Yeah, I think so we traditionally have kind of kept the conversation during these meetings to members of the advisory council. And I think towards the end of the meeting, we've chatted about maybe opening up the floor, at least to maybe elected representatives. So I'm gonna I'll keep going for now, but thank you for that. And I will try and keep an eye on comments. So next, I wanted to talk about this concept of kind of creating an agenda for analysis, which again, I really see as, Trisha's internet went out, but I didn't, sorry, more technical challenges. Let me see if I can find her. She had to. Okay, great. Sorry, thanks for the patience, all. So looking at formulating an agenda for analysis, I wanted to kind of think about categories of work just to begin organizing this and making it, something tangible to dig in on and figure out a way again to bring some focus to this because the opportunities are so wide open. There's so many directions to go that I want to have a focus. And I see this, I said 2023, 2024, I'd say I see it as late 23, first half of 24, potentially. I want to be pretty ambitious about what the office can produce, but generally really thinking about a few different categories. First, spending and cost growth, which again, really clear mandate for the office to analyze that. So I see that being something that the office does on a recurring basis. I really want to start a process where we have some expected reports that we produce annually that make it really easy to do that sort of year to year trend watching because we're consistent in the measures that we're using and the data sources that we're using. I'd like to do a deep dive on insurance enrollment and affordability. It's come up, and again, I think can find a source for one one segment of the market somewhere, but want to do a little bit more of a comprehensive look there. And I'll speak a little bit more to that. And then the last category is the legislatively required study of publicly administered public option models that we have. So I ended up going with analysis instead of research for this category because it's maybe not brand new research, but a few different focuses for analyses coming out of the office. Yeah.
Thanks, Trevor. At some point, I'm not quite sure when to raise this, but the terms are coming up here. So I think it would be helpful if we defined cost, price, and affordability, or at least define them for whatever context we're using them in, because that's one of the real challenges. What's affordable to one person is not to another, and what's affordable to an employer may not be to an employee. Price, as we know, can mean a whole variety of things. Are we talking about, and cost, same thing. So, are we talking about expenses? So I think that's just, they're used interchangeably oftentimes.
Yeah.
And everybody has a different definition, so.
A couple thoughts on that. 100%, I think it's a great flag and I'm happy to do that. Maybe I was sort of envisioning that at our February meeting, we do like a deep dive on this analysis work. And so that might be the right time to say, let's define those terms. I feel like I've got a good sense of definition in my mind, but I admit I slip up sometimes. And when I'm just sort of talking, I might
We all
use price and I don't always mean it as like the actual reimbursement, but I'm happy to define those. We can talk about them and then I will work myself to become more and more consistent on them.
The issue of defining affordability, I think, is a really challenging one.
I don't,
Yeah, just what do we mean though? Are we talking about affordability for employers? Are we talking about affordability for patients? To me, that we don't have to define affordability. Cost is the one though, cost to whom?
Yeah.
And that's one that gets completely used differently in different contexts.
I will say, I think on the affordability question, I'm relieved. I was gonna say, there's some interesting work other states have done on this, like Connecticut has created an affordability index, but I find those always to, it's really hard. It's so personal and individualized that I don't know that we want to go that route necessarily, though it's interesting to learn from. But I think affordability, I will try to be consistent in using that to talk about consumer experience and if I'm talking about it in a different context to call that out, say in this context, I'm talking about the cost for the employer, but I think generally I would say I'm talking about consumer experience and now, what that means in terms of like both premium and out-of-pocket costs. Obviously, there's some, it's not a totally clearly defined concept, but I think in general, fair to say that that's how I would be thinking about affordability just because of, kind of the office's charge in that regard. But the others totally hear you on it being, somewhere we're really digging in and writing out clear definitions is helpful.
So just kind of on that affordability, and as you mentioned, like the office's charge, because I think it's individuals, especially as individuals and small employers, maybe. And then just wanted to, so in terms of insurance enrollment and affordability, I'm assuming that that's looking at not just like premium affordability, like affordability of a plan, but kind of like more
service.
Yes.
Yeah.
Yeah, if I'm talking premiums, I will try to always be good about saying like premium specifically, but consumer affordability for insurance, I would say premium out-of-pocket cost and others. Yeah.
So could we even take a step back and talk about affordability of healthcare? Because it's not just insurance, right? It's the affordability of healthcare. So for people who may not have insurance too. So I think we need to it just gets confusing. So if we wanted to limit the discussion really to affordability around health insurance and including an out-of-pocket costs, that's one set of definitions. And I'm not advocating one way or another, but I just think it really does get very confusing very fast. And there are a lot of expenses out there related to healthcare that don't fall into some of these categories when you define them more narrowly. But they impact the overall cost of healthcare.
To that point, I think that you can talk about costs for individual care. And separate that out. It would be good for us to be able to say, okay, this procedure is this amount, insurance pays this amount, the variability around, different areas. I mean, I think that consumer doesn't know how much it's actually costing if they had to actually go buy it as opposed to going for insurance. I think it would be really good for us to be able to illuminate that and to be clear about
The expenses.
where, right?
The
and where-
inputs.
Well, I think that's where we need to really get at what's driving.
Exactly. I agree. I think that's where I'm trying to get at.
Is it pharmacy, is it medicine?
Right.
Like,
Right.
What are the
is
input?
it?
Is it labor? I mean, the inputs at the provider level even, so.
Right.
I would say-
Next slide.
Yes, I just thought the same thing. I was like, what would inform that discussion? Because I will say, these are big questions. And we're not gonna be able to put out a report that answers all of it all at once. So I am trying to think about how to phase this. And I just wanted to call out, in the prior slide when we're talking, that's because I think it is worth doing an individualized analysis just of what the insurance side looks like, because it is something that we hear so much about from consumers. We know that is the vast majority of consumers, certainly not all of them, and people who are uninsured are not unimportant, but it's worth talking about what is the experience for consumers who do have insurance as like a mediator for them for costs. Because it's something that we can't capture in an analysis of claims data. So it's complementary pieces, I think, for now. None of these are intended to answer a question fully themselves. It's like, let's help inform the conversation a little bit. And I will say an analysis of insurance and affordability would include, and now I'm getting ahead of myself, but a look at who are the uninsured and what are the demographics.
I totally appreciate that and agree that commercial insurance costs, private insurance costs are a real issue. And if we look at that absent the individuals who don't have nearly as many concerns, who are on different concerns, but don't have cost concerns or affordability concerns, who are on public or main care in particular, if you can't, like from the health plan or health provider perspective, you can't look at one without looking at the other.
Yeah, so I
So
think we are looking at that in
Okay,
this
all right.
component of spending and costs.
I was trying to wrap my head around, I have some questions. So.
Yeah, it's a lot. This is a kind of graphic enough framework for thinking about this issue that I wanted to give credit. Peterson Milbank Program for Sustainable Health Costs put out a data strategy guide for states a couple of years ago that again was really just helpful to me in terms of like trying to think about putting a form around this. So there's a lot more to talk about in this framework, but I thought it was a helpful starting point. So kind of their recommendation, which I think would be a helpful way for us to think about this work, is you really start by asking where spending is problematic. And by problematic meaning either it's high, and when we talk about high, you know, by default, we have to think to some degree about comparison. So that can be comparison within the state, comparison to like payers outside the state, comparison to Medicare, thinking about that component. And then where is spending growing at a faster rate than in other, you know, services or categories. So kind of trying to define that and take a look at sort of like a baseline so that you can start to narrow the work a little bit, because right now when it is every component of the health system, it's hard to figure out what are the next steps and how do you dig deeper. I see Jeff's hand is up, so I want to pause there and let you weigh in, Jeff.
Yeah, no, thanks, Meg. You know, I think in that middle box, you know, what's causing the problem, and maybe this is encompassed in intensity or volume, but you know, a lot of you know, new treatments and new modalities are pushing costs up pretty significantly. You know, if you you know, I get to work on, you know, our own self-insured health plan, and we certainly see that you know, as an impact. So I wouldn't want to leave that one out.
Yeah.
Is it safe to assume this is not meant to be an exhaustive list here, or we are trying to fit everything into these 5 bullet points under?
By everything, do you mean all analysis by the office or all potential component drivers?
Categories.
I guess, yeah, categories that the office is going to consider.
I think that we could grow the list. Like part of the reason I wanted to present this was so that we could have a conversation about it and I could get feedback. I think I would want to make sure we right size it only
Manageable,
because
of
exactly,
course.
like
Yeah.
I don't think we need to be limited to this if there's something missing again. And even the Peterson Milbank paper was very much kind of like a working, evolving something for states to build off of. So I definitely think, yeah, there's room for additional categories or different categories here if they make more sense. But I do think getting to a place where we feel like we have, in your word, a manageable set of categories, so it's not everything, it will be helpful in actually moving the ball forward with an analysis. Was there, maybe I'll just quickly go through the additional sort of sections here, and then we can chat more about it, because I'm curious if there's one in particular that's jumping out in terms of kind of what is causing the problem. So I think getting to you know, some of those answers that I've referenced, knowing that we don't have to this point, talking about price, by which I sort of mean, you know, unit price paid for a service. The volume, so we've talked a lot about, again, means aging population, and that we may just have higher utilization of services here because there's higher health need in that population. intensity, which I do think would get to what you're speaking about, Jeff, in terms of kind of higher cost, either sites of care or modalities of care, population characteristics, which would tie in my mind to volume, but we'd be able to more clearly answer the question, like, is volume driven by population characteristics? And then provider supply. So some of these questions that we had about, shortage of potentially primary care and higher cost sites of care. I see your hand, Trish. I'll just quickly go to the who is accountable. I think about phasing this, so I would think about, like, can we start with the first one? And then I think there's a lot more work to do about how you begin to define the who is accountable, but then generally trying to think about that as, is it a state policy issue? Is it an issue that a market intervention can control? Is it at the payer level, which, within market would mean a specific health insurance company, I would say, or a government payer, or the provider level? So, it's a lot. It's a big framework, but it's also the best that I found in terms of, like, grappling with the really valid questions you had, Katie, but getting us past the point of, like, talk about experiences and anecdotes and assumptions, and really getting to a place where we could try to say, like, with data, can we answer that question of, is it input costs or is it something else? So that's my thought. Trish did have her hand up as I was talking, so I want to go to her first, but then hear from others.
Yeah, thanks, Meg. And I'm sorry I'm having issues here, but.
Oh, sorry, Trish, I didn't see you rejoin, so my fault there.
That's okay. The joys of repairs. I think any framework we can pick at, but I think this is a really comprehensive one. The one question I'd raise, and I have, is on provider supply. Do we also talk about provider structure? There's some fascinating research about the costs of consolidation. And as someone who spent a big part of her career helping to consolidate, it'd be interesting to know what those implications are in Maine.
Yeah, I was going to suggest basically the same thing. Provider supply seems like it should be a sub bullet of just sort of the overall infrastructure challenges with the provider system, whether it be consolidation or,
Lack of other providers.
Or
Access.
how services are structured throughout the system and delivered throughout the state. And then I was just in the spirit of collaboration to acknowledge Katie's point. I'm not sure if we want to bullet on sort of the administrative complexity and burden that exists throughout the system to look into.
Administrative, but I guess my brain is looking at this a little bit differently. I have a pyramid in my head, and at the bottom are what is driving provider costs. And then the next one is what is different that's driving insurance costs. And then what is driving employer costs that might be different from what's driving insurer costs. And then at the top, what's driving the cost to consumers.
Mm-hmm.
And that and to me, one of the pieces that's missing, I mean, it's sort of tangentially here, but that what's driving provider costs, which insurers will always say, and I'll look at Dan, we're the insurers, we're just the pass through. So it's the provider cost. And I'm not seeing clearly here that piece of it, which seems really important if we're going to get our arms around cost.
Yeah, I think that's a good question for me. The point to consider is where that would fall.
Yeah.
My question would be sort of like, does that belong after who is accountable? And if you have made the, not assumption, but the finding being, right, those issues would be incorporated into price, and then think about accountability to provider, but then saying, like, accountability to provider doesn't necessarily mean you can just solve that problem yourself. It would be more of a, okay, if the provider is accountable, then what are the pressures on them that influence price? Does that make sense?
It may be my concern, quite frankly, is that if we are doing this in a very systematic and thoughtful way, so this takes a couple of years to go through each of these pieces, and we've got in what's causing the problem highlighted, that lawmakers will come up with solutions to what's causing the problem without understanding the fundamental underlying drivers.
Yes, that's fair. That's good feedback. I will be honest, I don't have an answer to it now, but I'm happy to take that back. And
So it
think
might
about
be-
it. There's a way to.
There might be just a timing issue
Mhm.
related to looking at that piece of it. So I'll think some more about it too.
And I will also say, I think maybe I did mention this or was going to on the next slide. I really see mostly that kind of first category, that figuring out like where is spending problematic and what are some areas we want to focus on as being the first phase. And I don't necessarily, because I think that bleeds a little bit into that second component here of thinking about breakdown. But I see your point in terms of not just what is the analysis, but like how is it rolled out and with what context, and if context is missing, it could be misinterpreted. So it may have to do with the structure of the analysis itself, or thinking about like how our work products combined and released.
Thank you.
So one other thing I'll just say is it's not as clear, but I think there's something to be said for things like volume, intensity, population characteristics influencing, operations. I get that it's not inclusive of everything, like, workforce costs potentially, so can give more thought to that. But there are components, I think, of that piece that inform the question.
And actually economic, if you just added a bullet related to economic characteristics or something, that certainly would help.
Yeah, that's good feedback. Thank you. I'll move along. We can always come back to this slide, but wanted to do sort of that deeper dive into thinking about what the first phase could look like. Measuring spending and trends, so really kind of looking at point in time and then change over time, is a section where I think we actually have a pretty good start in the baseline report that MHDO has produced. I will also say I view especially that first category being almost entirely probably MHDO data, with the one caveat that I think some demographic variables are included in that report right now. It's really by age and gender, I think. I would like to have some conversations, and it will definitely be a conversation about, for example, race and ethnicity or language spoken as ways to kind of try to make sure that we're considering health equity as a goal in this work and differentiating that as much as possible. That being said, I know that size of population can become really challenging there, especially when you're dealing with something like claims data. So I can't promise it, but it is something that I want to explore if we could expand those demographic considerations a little bit in the analysis, but trying to get into that analysis of spending. So this would not be by any means like a big comprehensive answer, just to clarify that in case it helps at all with any concern on your side, Katie. Like really we'd be talking about pretty large segments here. So just talking about like what's the trend in market by price, volume, intensity, what is the geography, just so that there's like that one level deeper that helps us narrow a little bit, not like saying writ large in vain, the problem is volume or anything like that, just starting to advance the analysis. And I do think that that helps get us closer to being able to identify ad hoc analyses or priorities. And then a section that I wanted to add, and this is definitely one that will need the most work from my perspective, but again, something I really wanted to socialize with the group, and it may be that folks in the room or in the advisory council or others have ideas about this, is I'd like to right from the get-go try to think about what are some ways of assessing access and quality so that we can build that in from the beginning. It's not kind of like an afterthought, it's something where over time we can be tracking that. So, in future, if there are thoughts about policy interventions, there's already kind of a framework for how we measure and view that. So a few ideas from Peterson Milbank and others are, clinical quality reporting. I know that's can be a challenging area and lots of nuance in that data, but and so again, very early days here. I'm exploring and looking for input on this, but trying to think, are there a few clinical kind of measures of outcomes that we would want to make sure that we're tracking? Could think about, what are some common diagnoses, some ways that we feel like are just good ways to kind of like keep our finger on the pulse of quality of care. self-reported patient access measures. I think there's some reporting through our agency on healthcare research and quality that again may have their downsides, but trying to think about, are there some ways that we could, again, just get a sense if there's significant changes in how folks are experiencing trying to seeking out care, and then trying to think about maybe provider panel composition or other ways of making sure that practices or health providers aren't excluding certain patients based on changes. Sort of, again, going back to the health equity consideration, trying to kind of keep an eye on that. So that's the one I have been
Like
working.
different pay, excluding like public pay patients or what?
Mhm.
Yeah, okay.
It's a big one.
Yeah.
Some practices.
That's a real can of worms.
Yes, it is.
It's a lot. It's a lot to think about. I'm not saying it isn't, but again, because it is challenging, I think in some ways better to like outside the context of search of thinking about a particular policy intervention or outcome, like good to kind of have the conversations early, and then especially because that section more than the others that would be more, MHDO, that would be one where we'd probably be needing to pull from different sources. So making sure that we have, inputs for that, know release schedules, kind of have a really good sense of how to watch that. I think would be an interesting thing to do. And I will also say I haven't had a chance yet. I know that, there's some overlap here in probably with main quality form work and sort of existing work. So don't want to duplicate anything. My goal would kind of be to probably try to pull from existing reporting and efforts and certainly not institute anything new. But I think kind of highlighting it in this way under the office's work is an important thing to do to kind of get at the concern the hospitals raised about making sure we're keeping an eye on this.
And we can do it without judgment. I think that it is a fact.
Mhm.
So I think that's fair.
And to some extent, I view this as probably to the extent we can, it wouldn't work for all of the segments, but like sort of similarly thinking about looking at these geographically and are there changes geographically or based on demographic variables, rather than totally holistic, but also not, this isn't something where we'd be like looking at a provider level or anything and measuring folks out. So. Any thoughts on this one from the folks who are virtual? Oh, sorry, did you want to?
Yeah, just a real quick question of the self-reported patient access measures. We already have those types of things in place, or other states have those, or how would you envision accessing patients' access as well as quality?
Yeah, so there are, it's the CAP survey, consumer,
HCAPS.
I think, yeah, consumer, this doesn't help. Something, a federal agency designed that survey, and I think that providers or payers have a responsibility to share often with consumers. So there are, I would have to look into it. Years ago, I did some quality work, and that was a component of it, so that I know that it exists. I would have to revisit, how strongly folks feel about it. But the nice thing about it is that isn't always just about like an encounter with a provider. It's, questions about like, were you able to get the appointment in the first time? Place, and how long did you have to wait? That can capture things that like a clinical reporting process would.
I can bring back to our next meeting or connect with you because that's all undergoing massive change.
Right.
Because it was so laborious. We didn't get a lot of
Right.
Information from it. So it's now down to like 5 questions or 6 questions and done electronically most of the time. But there is, and what I don't know is what those questions. So, but I think that's I'm sure we can get proxy data around access, even if we can't get actual consumer reported measures.
And
waiting lists.
Yeah. A nice thing is if you're, because surveys are, we know that they have their issues in terms of responsiveness, but especially if you're looking at it specifically for like longitudinal change, you don't have to worry quite as much about like our response rates low, because as long as you're not necessarily understanding it might not be holistic, but like you're going to see if there's a really significant change in how you.
Well, I think that also, we access some of those and we say, oh, this is not worth it. This is the data we really think is solid. That will get one of the results or recommendations coming to this council is to say, we need to step that up. We need to make it clear consumers have a strong voice on price and quality and and so on, and make it as simple as possible so people actually say, I have a voice in this process.
I'd also just want to flag, in terms of access, and I'm not sure how to get at this, but in terms of measuring like the access people have, there's people who aren't seeking care or aren't able to get care. And so how do we capture kind of
Mhm.
that demographic too, that won't be captured by like a provider survey necessarily? Because they might have just gone without.
It's a great.
I think we should try to find, everybody should be able to access the care that they need regardless of ability to pay. I think that, but they may not realize that, or they may perceive barriers.
Right.
So I think that's, but we should try to.
My one thought, and I was like, I'm getting very ambitious, so maybe I shouldn't say this out loud. That it would be nice, like the survey would be the way to get at that, right? If you're trying to just like get everybody regardless of interaction. So trying to think about, my immediate thought was like, oh, should we just think about a survey there? But I wonder if Berthas, if there's, if we could like select a survey, and to your point, maybe there's a role for the office in trying to promote it or encourage participation or encourage, even further efforts to collect more responses. So I know that might be something to dig in on more, like the relative value and benefits of different surveys around this, but that would be the way that I could see if we wanted to pick one or two questions from something like, and again, I'm like, I know acronyms and not the words, but Berthas is like the CDC annual state level survey that covers a lot of sort of health status questions, but they do have a section of that survey that's focused on health cost and access. So that could be a good source for that.
Medical debt is not here, and that might be a way to start to measure affordability, from an individual perspective. And I know that's a high number, so.
It's a great point. Yeah. Note that one down too. Renee, I saw that you have your hand up.
Yeah, thanks. So just a couple of comments. So one is that, I think that there are a large number of Mainers who are not seeking certain kinds of care because of financial constraints. So folks that have insurance and folks that don't have insurance, whether it's that, the medication copay is too much, or their deductible is too high, or, they don't have insurance, so they can go see a doctor like me who will see them without insurance, but then, can't get the medication that they need, or, so I think it goes to that affordability question, like what is affordable? But then also I think, how do you capture the cost, the downstream costs of people who are deferring care for financial reasons? And I think that that's happening, like I said, for people with insurance, people without insurance. And, none of that's going to come through claims data because it's care that's not happening right now. So I don't know how you get at that. But I think that that's happening. I see it in my patients every day. People are making choices about things they're not going to do because they're worried about the cost.
Right. Yeah, totally agree with you. And I think getting at that question of kind of rates of delayed or deferred care is one question I was thinking about on the survey that Kate conducted. I do think there's ways through surveys to assess to some extent how frequently that's happening. But I think that issue of, okay, how do you interpret that and try to then look at either claims or maybe it's hidden data, sort of medical record data, try to draw a connection between delayed care and then the higher costs when people haven't sought care early on that might have been less costly and helped to prevent higher need. So I'll try to look into like whether there is any opportunity in these categories to get at that. I think intensity and others would miss it, but it's a great point. And I do think that it's one that's worth trying to incorporate. Again, it's just that question of where that falls and whether that's something where it's like if we've identified certain services as a driver, that's then a follow-on question is part of the issue there that, you know, patients haven't sought care because of cost. So here you don't have a clear answer on how to do that, but I will give that some more thought as well. Anything else on this one? So I think that I might have, actually, I'm not sure that I did because I was thinking ahead to the February meeting. I'll talk more about December, but I think I've already kind of got an agenda in mind for that one. But I was thinking that probably by our February meeting, I'll be in a place to kind of come back and talk in more depth about this and talk about more next steps. But I wanted to kind of gather some early input. So next kind of touch point on talking about what this analysis looks like then. On the insurance enrollment and affordability piece, I just wanted to, you know, flag, we have some outside support from folks at the Urban Institute to help with this analysis and during the discussion of what they do. So that's why to some extent, you know, methodologically, this one is more complicated. It's more data sources to pull from. But again, I thought worth doing just because it is such a theme that we see. I think it's helpful in answering the question and trying to determine, like, do we see areas of opportunity that are more focused on the insurance level or, you know, particular gaps that are worth the office kind of prioritizing. So I view this as having a few components, thinking about distribution of types of health coverage to really kind of market segment in Maine. And then thinking about or looking at detailed demographic breakdowns within that of age and income. I have it at the bottom, but really it sort of belongs there. That would include looking at who the remaining uninsured in the state of Maine are. Something that I thought a lot about in my prior role, trying to think about, you know, the drivers there and kind of Katie, to your earlier point, there's a really valid question here. I think between there's absolutely affordability barriers, but sometimes there are perceived affordability barriers too. And sometimes when you get folks in the door and can help them out, you know, they are able to afford it. So I think getting like a clear idea of how we see that breaking down would be helpful. And then kind of addressing, Kate, your question from earlier about this analysis. Want to think about distribution of health spending on both premiums and out-of-pocket costs and think about that as a percentage of income. So starts to get towards that question of what is affordability side, putting it in more context than just like, okay, what is the number? Like really trying to understand how does that exist within the budget and income of families and Pennsylvania. I wanted to put the bullet in there because it's come up and I continue to be interested in this issue of like, especially when we're looking at employer sponsored insurance, are there ways that we can account for the availability of HSAs and their utilization? So no promises there, but I am gonna see if there are any data sources that the urban folks, you know about that they might be able to tap into that I have not found so that we can try to, you know, make sure we're incorporating an understanding of that into that segment of the market as we look at it. But I'm hoping this will be, you know, something I've taken a look before at other data sources, and you can do some high level thinking about this in terms of, for example, census data on breakdown of how people respond about health coverage and their income type, but it becomes more and more challenging as you dig in levels and levels deeper because of our small population here. So some of Urban's ability to do modeling based on experience in other states with Maine data, I think will help to paint a little bit of a clearer picture here. That hopefully is helpful for us and in our conversations, but I'm hoping helpful for others too, like the marketplace who are trying to think about targeting of advertising and Maine Care for outreach and other parts of state government as well. And then the last study component that I had or analysis is the study of public options. So just calling back for those who might not remember, there was a study requirement for the office several years ago that included sort of a wide array of different policy interventions. And then during the last session, the Health Coverage Insurance and Financial Services Committee was really focused on public option plans. And there were a few bills introduced around sort of pursuing various models of public options. So they decided to kind of narrow the focus a little bit and asked me to prioritize delivering to them a report that looks specifically at publicly administered public option models. So not looking to necessarily contract out to existing payers, but really have the state administer something themselves. So I've been working on outlining this and thinking about a framework for how to do this. I wanted again to kind of share and have an opportunity for input. So I really want to focus in the report on talking about what the goals are for a public option and how that relates to design decisions. You know, public option is used a lot, but there are very different models that have very different intended outcomes. You know, some public options in other states have been really focused on that population of people who are ineligible for other coverage, and others have been really focused on concern about lack of competition in their individual market and wanting to make sure that they have competition and some stability. So there's not sort of like one thing that a public option model is. So the way that I've kind of broken down those design decisions and again, tried to bring some structure to something that can be very broad is thinking about eligibility and availability. So by eligibility, obviously mean who is allowed to buy it. Availability, I mean more of like, who is it intended for? Is it a product that's being sold on the marketplace or off the marketplace? Some of the considerations that go into that decision. Definitely thinking about the benefit package. That's, you know, something where there's been a lot of interest in the really comprehensive benefits that MaineCare provides, but, you know, thinking about how that relates to meeting actuarial value requirements in the marketplace and competing is worth considering. And also how that feeds into the next point, which is pricing and market impact there. So both, you know, what does the price look like relative to other options that are available to the population that you're trying to serve? And also touching a bit on potential unintended consequences of that, you know, introducing new products into the marketplace has implications for what the subsidies available from the federal government are, and want to talk through that a little bit. Administration, again, touching, and then clearly I have a bit of a mandate there, but I want to have some discussion of it in terms of the state being fully responsible for administering the plan versus contracting that out. And then thinking about how would a plan promote quality of care and equity of care in the state as well.
But just a question, are there any public option models that will involve rate setting by the entity?
Not existing ones. The landscape is still, I would say, really new. The example that I can think of off the top of my head is and don't quote me on this, I'm not 100% sure, but I think in Nevada, when they were discussing having a public option, they were thinking about contracting it out to a third party that would negotiate rates. And I think that they were really focused on the market stability. They had Bexar County problems. So I think that it was a little bit less of a, you know, they wanted to make sure that there was an option available to people and had demand for it. So it sort of wasn't coming in necessarily and having robust competition. I could be wrong, but I'm fairly certain. And I don't remember how advanced they got in talking about that model, but if I'm remembering right, I think that was there.
And then I think in some, like certain rate setting provisions kick in only if certain metrics aren't met too. So it's kind of like a,
Yeah.
an authority to do rate setting in certain situations, but not necessarily.
So, what I recall from the conference in Chicago on healthcare costs, were the two states that did have successful rate setting, programs were Massachusetts and Rhode Island. And particularly Massachusetts, I really got my ear, and I really think that they've been successful with that. So similar rate setting that we do with PUC and so on. So I think that, you know, there are models out there that we could certainly look at, whether that's, you know, developing a public option. I didn't hear a lot of that, I don't think, in that meeting.
I mean, to pass judgment one way or another,
Yeah.
just as pure curiosity.
I did have a question. So I know that the legislature gave kind of a focus this year on the publicly administered public option for your initial analysis. Is this like an initial analysis and that subsequently the office would look at other models too, or is this?
Yeah, the requirement has me delivering a report on like sort of
Right.
all the remaining models by January of 25.
Got it.
Which
That's right.
maybe sooner, honestly, too. I will say the way that I'm approaching this is, again, I think there's a few folks on that committee who are really interested in this model. I think it's good for us to like have an in-depth discussion about it. I do think, you know, and I've been having some conversations and kind of gathering some data, the costs of startup of a publicly administered plan are really high. And so it may be that the group sort of looks at that and wants to consider alternatives, but I struggled with this a little bit too, but I kind of want to keep a narrow enough focus that again, it's like a manageable
Right.
report on this
Right.
area. And then
What was that LD so that established this study? You know,
a few months ago, I would have known it off the top of my head.
All right.
I don't know what the number.
I'll find it. I'll find it, but I'll find it and send it to y'all. Because I think it's important for us to know that we're being charged to do this.
Yeah. It was,
Or-
I shared at the first meeting that we held, I think I put on the legislative link
Yeah.
for that, so I can send it around again. if
That'd be
it's
great.
helpful. Yeah.
Yeah, please do, because I think that it's important that we, you know, that they're also gonna do this. What they really want.
Yeah, and it's my read of the legislation, but also had, conversations around this with a sponsor during the last session. So I think I have a pretty clear idea.
LD 329. It's Tipping's bill.
No,
Hartford.
No?
no, it's Poppy Harvard's. Yeah,
1856.
They are-
Consideration of a public option health benefit plan.
Yeah, there were like five.
Just
Just
the-
my father's was the one that finally survived.
Yeah, then I think it's 1856. That was first.
Yes, I'm kind of sure that was right. I
That sounds right.
had a feeling it started with 18, but it's
So do we have a number?
1856. So then thinking about those criteria and sort of including a discussion of that framework for thinking about these options, I then wanted to kind of outline 3 generalized models. Again, this is all a little bit mix and match. There's different ways that you can configure them, but this felt like a logical sort of 3 categories that could be considered. The first is really thinking about like, what would it look like to introduce a publicly administered plan that is really focused on individual and small group market, probably clear choice compatible, a little bit more of like a clear competitor essentially to the existing individual small group market. The next being an eligibility of expansion for main care. This is something that New Mexico has been looking at and thinking about. I will say there are some unique characteristics of states that make the consideration of this different in different populations, but kind of thinking about what would that model look like here in Maine. It's not widely used, but there is an option to expand eligibility in the Medicaid program and receive some federal match for it. But you are trading off essentially subsidy eligibility for that. You can't combine those 2 sources of funding. So thinking about that, and then the last option, thinking about like a lookalike plan. So a plan that would not be eligibility for main care and wouldn't receive federal matching funds, but that would look like the main care in terms of what the benefit package looks like and what the provider network
You would
looks
buy
like.
into it.
Mhm.
You had an option to buy into the plan.
Yeah, I mean, cares any willing provider, so that's network. So that's really interesting. It would be fascinating just because it's the benefit is so rich.
Yeah.
I mean, it covers lots of things that, no one else covers.
Mhm.
And it doesn't pay providers.
I was gonna say that would be a component of probably both the expansion and what like a lookalike program would be. I'll say in the main care, in the eligibility expansion model, I mean, I'm definitely not an expert on it, but in what New Mexico is doing, they're anticipating enough savings that they would see an increase in provider rates across their entire Medicaid program. That's what they are anticipating from this kind of concept paper and policy proposal that they've put out. So there are some interesting dynamics here, definitely. I think you have to think about like in that lookalike option, is it something where you're saying in order to be a main care provider, you must be within the network of this plan? That probably functionally is how that structure would look.
Yeah.
But yes, definitely, the benefit, but that being said, I think that the charge was clear for members of the legislature that there was a lot of interest in this idea of, we hear good things from people about the main care package. We want to know what would it look like to make that available to other people. So I do think I'm working now on seeing if I can get some numbers behind this, at least like a back of the envelope, but I'm considering like what would a sound premium look like for a benefit package like that with very, very low cost sharing is, part of what I want to accomplish in terms of like moving that conversation forward and beyond the very high level theoretical and more into like the nuts and bolts of these different models. Again, recognizing that each of them, there's so many design decisions that you can make that I don't think there's any way that I can kind of write up an analysis, but I think that this will be enough substance that it allows for a more in-depth conversation and a decision about further exploration of either of these models or alternatives potentially. So that's really my goal. Great. So I think I've got just a few more slides on kind of upcoming events. As I noted in that August meeting, a lot happening. I wanted to briefly just share, mostly as an FYI for this group, many of you might have already seen it, but CMS maybe a month or so ago announced a new payment model and a solicitation that they're expecting to come out before the end of this year. It'll be interesting to see if it comes out earlier than expected, if there's the government shutdown looming, but it's sort of a unique model, or at least unusual compared to some of their other more narrow targeted models. This one's a little bit more expansive. It's the state's advancing all payer health equity approaches and development model, but they are calling it AHEAD. It's a total cost of care model that combines primary care investment, the capitated payment with adjustments for quality and hospital global budgets for the providers that choose to participate in it. The goals are to improve population health, advance health equity, and curb cost growth. And one thing I wanted to especially highlight about it, that again, I think makes it stand out a little bit, is that it specifically requires multi-payer participation. So states that pursue this model will have to commit to having at least one commercial provider with a significant enrollment participate in it. So I wanted to highlight that while I had a bit of an audience, because I think, you know, I know our health systems payment models are very much on your radar. For some of the payers, it might not be something that you're tracking as closely. But my office, again, has a chart looking at different value-based payment models here nationally. So I'm learning more about this. And there's a couple other learning opportunities wanted to share. Nashville, I think in collaboration with CMS, is hosting a webinar on global budgets on the 26th. I was going to put the URL in, but it's a little bit long. But if you go to NASHP's website in their event tab and webinars, you'll see how to register. And then Lisa Letourneau from here in DHHS is hosting a briefing that CMS representatives are actually going to come to. That'll be Maine specific just for our state. You know, again, very much a learning opportunity, but she wanted a chance to make sure that anyone interested is able to get up to speed, able to ask questions. So wanted to highlight that as well, just to make sure folks in the group are aware of it. We could spend a long time talking about the model, and I think there's complexity that we probably won't know and be able to kind of talk through until that notice of funding opportunity is actually released, that has kind of all of the detail, but it is something that has a relatively tight timeline. So I think there's just a desire to kind of start fostering the conversation, getting people thinking about it. And then we'll see if it makes sense to have additional conversations about it. The November convening, I'm at that point in event planning where I am, you know, reaching a turning point and feeling anxious about this as my next upcoming event, but excited about it. Wanted to share November 15th, 8:30 to 4 p.m. I'm going to send out invites to some other folks later today. I had put a specific location in at University of Southern Maine, but I generalized because I've been going back and forth with my contact there, and we might have it in a different building, but it will be on that Portland campus. I wanted to just share a reminder, in-person attendance will be invite only. It's not a super large space, and given that it's an all-day meeting, just have to put some limits there to make it work, but we're going to record and share that on the office's YouTube channel. So mark your calendars. I hope folks can make it, and I'll send this out in a reminder after the meeting as well. And then I wanted to touch on December's advisory council meeting. I should have put the date on here. I'm sorry that I didn't, but it's the 19th from 1 to 3 p.m. In terms of the agenda for that, I'd like to hold some time and assume that there might be, you know, sort of a readout and some discussion that we want to have around that November convening. And I'll pause. Sorry, Renee, did you have a question or comment?
No, sorry, I'm having hand issues.
Oh, no worries. Just want to make sure. The next item that I had on that agenda was reviewing outlined and draft legislative reports, so kind of leading on from this. My goal would be have a draft of the annual report to share, a mostly completed draft, and then at least an outline of that public option analysis. So we can have a little bit further discussion about those before they're submitted to the legislature. And then I imagine that there may be some legislative items that are worth touching base on. I don't know that we'll have items for that, but anticipate that we may. In particular, I was going to call out, I did recently hear that the group that's been tasked with looking at patient costs and facility fees that is going to be convening soon. I think there were some limitations on when it could, given the end of the legislative session. So I think they're anticipating that around the end of this month, and then the group is supposed to be providing recommendations on December 3rd. So it's going to be quite an intensive process, but there may be some readout from that or on other topics that are worth providing an update on. I also, after having some conversations with a few folks, I really want to just set a meeting cadence for 2024, so we can just put it on calendars and commit to it. I know of one person who was struggling with attendance because of a standing immovable commitment on the second Tuesday. So I want to go with the first Tuesday of the month and move it up to 10 to noon, because I also got some feedback about it being difficult kind of having a meeting in the smack in the middle of the day. So this allows people to have a little bit more of a free afternoon. So I will send invites for that, but just wanted to share that, and hopefully with the notice and awareness of sort of that will be our cadence throughout the entirety of 2024, that will be workable for folks.
The first Tuesday of January is the 2nd of January.
We don't have a meeting in January because
Right.
Every other month.
I did do a quick run through and make sure that it's like not on holidays and I think that it looked workable.
We never have Tuesday off. So.
That's a challenge. I had a big standing meeting on Mondays that I scheduled once, and I was like, worst mistake ever. That's right. So much time rescheduling a meeting more than you spend in it. So I did want to just do a check if there's anything else that's sort of top of mind for any members in terms of items that could be on the agenda for the next meeting or future meetings. As I kind of anticipate February likely being a little bit of a analysis next steps deep dive, but there may be other issues that have come up by then that are worth including.
So Meg asked me any takeaways from the healthcare costs conference that they went to that was put on by NCSL in Chicago. And it's the interesting thing is that they have you do this little QR code to look at all your stuff, and then you can't find it, right? So, but one of the takeaways that I did mention the rate setting for Massachusetts and Rhode Island, and I mean, I think there were multiple states from all over the country doing different things, but one thing, and I know we have our state health employee representative in the meeting here, is that the state health employees are the largest buying group in the state, in most states. And that by recognizing that buying power, recognizing that that consumer group has the ability to say, okay, we need to negotiate as to how much we're going to pay for insulin or whatever. So I thought that was interesting that talking about that and much to my chagrin, Katie, they focused a lot on hospital costs.
Yeah.
And really looking at the graphs
And
and
it was Arnold Foundation
right.
paying for it.
Yeah, and I think, yes.
Sponsor, that's why.
And then, but the other piece is, and we all know this, that out-of-pocket costs and deductibles are just going through the roof. There's no trying to intervene with how high they're going and how quickly they're going and why people choose not to get care because of that. I mean, to Renee's comment, I mean, I have a spouse who's not going to get shoulder looked at because he doesn't want to pay the deductible. He's going to figure out how he's going to get better on his own. I mean, he's okay, and I would make him go. If it was really bad, well, that's the average Joe who's making decisions based on that. So how those are reined in, how we work with insurance companies and so on because this is a huge hurdle, and we're going to start to see healthcare decline more and more because of that. And I think that the dilemma that we often face is that when we talk about affordable healthcare, and then we start talking about main care and so on, we have to I think it's important for us, and they talked about this a lot, and this was a very bipartisan group. Saying, you know, everybody needs to be able to afford care, as Katie said, no one should not access healthcare because they can't afford it, you know, and it costs too much. Those were my biggest takeaways about it, particularly, I mean, looking at other models, we do not need to reinvent wheels, and I think that that's one of the biggest reasons I went, and that's why I wasn't particularly impressed. You know, yes, demographics of Massachusetts, Rhode Island are different than us, obviously. And there were some other rural states that I think that I really like to look at more about how they're reining in their healthcare costs.
And I want to say that I don't disagree that hospital costs, it's not, that health system costs are high. I don't think anybody's going to disagree with that.
Right.
I think the issue is that's why I'm so intent on looking at what the drivers of those costs are.
Right.
Because there are some assumptions being made that I think may be accurate in some places, but may not be accurate.
Yes.
And I think it's really important for us to be clear and be transparent. I want us to be transparent about
Yeah,
it.
and be objective.
Yeah.
That, I mean, I think it's too easy to look at one industry or one part of the system and say, they're the culprit.
Yeah, I totally agree with that. And I think I said in our first meeting, I do know that oftentimes, you know, by the time we're in session, like that is when folks are reacting to legislation, there's a lot of that back and forth. And I'm hoping that this forum and this office will be an opportunity to look more holistically, because the one thing I'd call out is, you know, things like out of pocket and deductible, totally agree, problematic. And I hear you on again, like that more the relevance for the consumer being there, but there is also the relationship between like what are the drivers of that on the insurance level. And so, you know, trying to think about like the whole continuum and all of the steps there and where are the opportunities for us to intervene and do something about it is really important from a big health system perspective, but also frankly in actually delivering some kind of relief to consumers. Jeff, I saw that you had your hand up.
Yeah, simple question. Can you just go back to the previous slide?
Sorry. I talked
All right.
fast and moved right through it. I'll send this out via email too.
Yeah, no, I figured you would, but
I'll put it in the slide deck and share it. November 15th is the day.
And are you trying to do this by yourself without?
Yeah. Which is part of that's been a challenge doing the solicitation piece because it's also.
I know she's got to decide an analyst that maybe.
Yeah.
Thankfully I've done like some event planning, but yeah, it's not, you know, I can't just like sign a contract or I don't have a credit card I can give. So like just things like. Reserving space. We're gonna get there. It's gonna be great. That's just why. But I say I'm like,
If you'd like to call upon some of us to help, we'd be
Yeah.
happy to do so.
will do. I'll let you know. I think we're in good shape. And I am excited.
Also, I don't know if you're allowed to do this, but putting up a website for this, I'm healthcare for those. I'm helping you. And we have a website, Bing, it's like automatic, right? You know, it's like Bing, every commission gets a website. So my suggestion to you is, I have friends over there, call them. They'd be happy to get you, to help you.
I have been through that process before. I have a lot of familiarity with the state vendor and our, so it's, and lots of folks and DAPS has been helpful. In reacting. So yeah, it has not always been my experience, which is part of why I've been so fascinated by this. But thank you for the offer. And I do think we're close to the finish line and appreciate Heather and others helped with that. Because it is, again, just talking about sort of workload, it sounds so silly, but again, for me and for people, like the process of needing to send an email every time we have something to communicate with, not a great one. So I'm very much looking forward to being able to, you know, make everything easily available to everyone and share updates. It would be a great tool. Take us into the 21st century.
Well, we just, the privacy bills being heard over here, so we gotta be careful about what we do, you know, we want to.
All right, anyone else have comments? Great,
I'll move to adjourn.
sounds good. Second. Thank you all. Have a great rest of your day. Bye-bye.
Thank you.